When it comes to obesity and kidney health, one size doesn't fit all.
Obesity is a chronic illness. Obesity is not a condition. It is a chronic, relapsing, remitting illness.
That's nephrologist Dr. Eugene Menev. I'm Sarah Jane Castro, Senior Director of Marketing and Communications for the National Kidney Foundation of Illinois, and your host for this edition of The Journey Continues. This episode is sponsored by NANI, Nephrology Associates of Northern Illinois and Indiana. Hi, Dr. Menev. Thank you for coming on the podcast. Can you tell us what your work includes as a nephrologist?
Hi, Sarah. Thank you for having me. As a nephrologist, I take care of people with chronic kidney disease, people with impaired kidney function, high blood pressure, diabetes, and with inflammatory diseases of the kidneys. So it's a very broad spectrum of people that come to a nephrologist's office.
How long have you been practicing?
I've been practicing for about 20 years, give or take.
What drew you to nephrology?
It looks like was a perfect blend of acuity, intensity, and the ability to have follow-up relationships with patients, which I was missing as a hospital-employed physician.
So before you were with NANI, you worked in a hospital?
Yes.
How long have you been with NANI?
Almost 10 years.
Oh, wonderful. And I understand that you are specifically interested in the links between chronic kidney disease and obesity. Could you define obesity for us? Is it different from person to person, or is it one definition?
I became more and more interested to learn about obesity as I see that the rates of obesity in this country and in general in the world are skyrocketing. And obesity is defined, for lack of better definitions, by abnormal body mass index, which is weight over square area. And obesity is being defined as body mass index over 30. Severe obesity is defined as someone with body mass index over 35. In general, people who have obesity as a diagnosis usually will have other conditions such as high blood pressure or diabetes or high rates of cancers or sleep apnea. So not only that obesity could affect them based on self-esteem and body image, but also could affect their overall health.
We talk a lot in this podcast and in general about the link between diabetes and high blood pressure. If a patient's BMI or body mass index does put them in that obese category, but they don't have high blood pressure or diabetes, are they still at increased risk for chronic kidney disease?
I believe they are. Obviously, body mass index is not the best quote-unquote vital sign in order to diagnose someone's obesity, because some people could be very muscular and could have a lot of muscle weight, so this does not affect them based on their visceral fat quantity. So for some people, it could be more appropriate to use waist circumference as a marker of obesity. But in general, obesity affects every system in someone's body. And even if they are not morbidly obese, even if they have mild obesity or the beginning of obesity, they're still at risk for hypertension, they're still at risk for sleep apnea or diabetes mellitus. And as of this day and age, in the United States, there are approximately 39 million people with diabetes. Almost 10 million of them are not diagnosed with diabetes, even though they may have it. And to make it even more critical, there are about 97 million people who have prediabetes, which is defined by impaired insulin sensitivity and overall increased requirements for insulin to control someone's blood sugar, which is the definition of prediabetes. And ultimately, we know that 50% of the patients who end up developing end-stage renal disease develop end-stage renal disease due to diabetes.
Yeah, those are some startling numbers.
They are. By 2030, it's estimated in the US about 50% of the US population over 18 will be diagnosed with obesity, and 25% of the patients or people will be diagnosed with severe obesity defined by BMI of over 35 with a health condition.
Do we know the percentage of chronic kidney disease patients who fall into the obese specter?
I don't know the exact number, primarily because chronic kidney disease is vastly underdiagnosed.
Mm.
And we can only see the tip of the iceberg, but we don't really see what is under the water. Just because people can have chronic kidney disease just based on increased albumin excretion, which is a sign of kidney disease, even though they may have normal kidney parameters and they're not referred to a nephrologist. So the prevalence of the chronic kidney disease in this country is very underdiagnosed. I had heard some statistics that about 40 million people will be diagnosed with chronic kidney disease by 2040. I think it's going to be much more than that.
That's very sobering to hear. We've got a lot of work to do to get the word out and educate people. How does obesity relate to kidney disease? Can you walk us through that connection of how that excess weight affects your kidneys?
That is another difficult question to answer. It's a very good question because I think all roads lead to Rome in a way. People may end up having kidney disease due to obesity because they develop diabetes, and we all know that diabetes will affect someone's kidneys over time. They may develop high blood pressure, and we know that high blood pressure does cause kidney disease, heart disease, etc. Or obesity alone is a risk factor for kidney disease just because people who have abnormal BMI and abnormal weight will end up developing hyperfiltration injury. In layman's terms, the kidneys will have to work extra hard over time to be able to provide the same metabolic clearance as for someone with normal body weight.
How does obesity affect the efficacy of some of the treatments we use for kidney failure, like dialysis? Is extra weight a factor when receiving dialysis treatment?
Very excellent question again that can not be summarized in a simple sentence. Yes, people with end-stage kidney disease are at a huge disadvantage. Not only that they have to spend 12 to 14 hours a week in a dialysis center receiving treatments for the people who are going to in-center hemodialysis, and they don't have enough time or energy to exercise, but they're also placed at disadvantage because having higher weight takes them off of the transplant list, so they don't really have opportunity to pursue the ultimate therapy for end-stage kidney disease, which is transplantation. So they're at a huge disadvantage. There are only a few centers, at least in my area, University of Illinois, primarily, who will take people with abnormal BMI, which is defined as BMI over 35, to pursue kidney transplant. I can see why, because people with higher BMIs will have more frequent postoperative complications just purely from the surgery alone, and a lot of the centers are not willing to take that risk, or they don't have the technical capabilities of doing it. So we have a population who is already at disadvantage. They are already discriminated against because they have to spend day after day in the dialysis unit, but they can't really exercise and they can't really lose weight. So that was the primary reason why I got interested so much into this obesity conundrum, and I'm pursuing this fellowship in obesity just because I'm really bothered by the disparity of care, discrepancies of care, and the deficiencies in care.
Let's talk a little bit about that discrimination. I've seen reports from patients who say they feel like their concerns are often dismissed when they go into their regular doctor's office, and they'll just say, oh, just lose weight, just lose weight. But there's not a lot of conversation happening around that. What sorts of interventions are there available for patients who are really struggling to lose weight? Like if you're on dialysis and you're unable to exercise, what sort of interventions would you recommend?
Difficult question. we need to realize that obesity is a chronic illness. Obesity is not a condition. It is a chronic, relapsing, remitting illness. So it's an illness that requires lifelong treatment, unfortunately. There are multiple treatments, starting with counseling by a physician, which is, by the way, not always covered by insurance, counseling by dietitian, by behavioral specialist. There are surgical options for treatment of obesity, assuming that someone qualifies. And then there are medications for obesity. And I would have to say that the last several years, the treatment of obesity has become significantly more available and significantly more successful with the discovery of the new pathways and the new medications, and there are much more to come. So I do believe that in the next 5 to 10 years, there will be options. Unfortunately, we live in a very obesogenic environment, and humans evolutionary were genetically determined to be obese. This was a way to store calories in times where calories were not available. Calories were stored into fat because one would not know if they will have access to food for 2-3 weeks at a time. So people or individuals who were able to survive were the individuals who were able to store calories into fat tissue so they can have enough reserves for the times of stress and famine. The foods that we use in this day and age are very calorie dense and they're very nutrient poor, which is a very bad combination because you always want to have nutrient dense foods with micronutrients and not calorie dense foods with a lot of, super saturated fats and salts. On a different note, when we look into energy expenditure, in 1960, 50% of the jobs in this country required to some degree physical labor. So there was a lot higher energy expenditure and people could afford to eat calorie-dense foods. In today's day and age, only about 2 to 3% of the jobs require heavy physical labor, and most of the jobs require increased screen time, whether it's in front of a computer, whether it's in front of an iPad or TV. So most people spend 27 to 30 hours a week just working in front of a screen. It just puts them at a huge disadvantage. They don't have a way to spend any of the calories that they would consume.
You mentioned the drugs that are available. I know there are a number of drugs available that originally developed to treat diabetes, and then they discovered it was helpful with weight loss. What effect are those drugs having on chronic kidney disease?
I'm sure you're referring to the Ozempic and Mounjaro epidemic. Pathophysiology of obesity is very complex. Just within the last 20-30 years, we realized that stomach and the intestines are actually endocrine organs. They produce certain hormones. The stomach, for example, the upper portion of the stomach that's called cardia produces a hormone that's called ghrelin. Ghrelin makes you very hungry. So if you are trying to diet and your ghrelin level increase, you will find access to food because all of a sudden you become very hungry. Insulin is a hormone that lowers your blood sugar, but also insulin is a hormone that promotes gluconeogenesis and promotes storage of calories into fat tissue. The adipose tissue also secretes multiple hormones, one of which is leptin, the other one is adiponectin. So people who have obesity as a condition, usually they have higher levels of leptin but lower levels of adiponectin. So the leptin-adiponectin discrepancy promotes increase in body weight over long term. The newest medications that are very successful to treat obesity are developed as gastrointestinal peptides, one of which is called GLP-1 or GLP-1, glucagon-like peptide, and that is the semaglutide. The other one is called tirzepatide, and it's a combined GLP-1 and gastrointestinal peptide or GIP-1 agonists. They have many different actions, and we are always hearing more and more different mechanisms, how they work. But in general, they promote satiety. They slow down your gastrointestinal motility, so you don't feel as hungry and you get full very quickly. And also they directly work in your brain in an area that's called hypothalamus, and particularly the arcuate nucleus, where they work on particular receptors. So they make you not as hungry. They make you not actively look for food. So the combination of decreased gastrointestinal motility, decreased insulin secretion, and decreased drive to find food is what leads to this weight loss, which could be very profound. Most people lose about 20% of their body weight in about a year. So they've been very successful into treating this obesity epidemic.
And then in turn, does that improve kidney health?
I believe for sure. The question that I had for myself was whether this is by virtue of decreasing someone's blood pressure, decreasing someone's levels of glucose, and treating the diabetes, whether the improvement of kidney health is related. But I start to believe that actually there is a more direct correlation. I believe it's called the FLOW study, which looks at preservation of GFR in patients who are taking semaglutide. And I do believe that the preliminary data is very successful. It may have come out within the last month or two, but I do believe that they are shown to slow down the progression of the chronic kidney disease.
That's very encouraging to hear, but I know those drugs can sometimes be difficult to get your hands on if you're maybe not diagnosed with diabetes or something else. They can be in high demand.
These drugs are in very high demand. So we all know that they're in very high demand, and they've been promoted by multiple TV stars and personalities because they're very successful, and they're very expensive too. And the cost, I think, at this time is over $1,000 a month for both semaglutide and tirzepatide. They are approved for patients with diabetes. They're also approved for patients with obesity. Not all insurance carriers will cover them, which is the difficult part. And there are marketed for obesity under different names. For example, Ozempic is marketed as Wegovy from the same manufacturer, I believe it's Novo Nordisk, for treatment of obesity. And alternatively, the Mounjaro tirzepatide is marketed as Zepbound for treatment of obesity. So they will be approved, but the coverage is very sparse and sporadic. So you would never know if it will be covered by a certain insurance carrier. They are helpful in patients on dialysis. They are usable in patients on dialysis. There is no significant adjustment. And they will be very helpful to improve someone's blood pressure, or someone's chances of receiving a transplant, and so forth. So I do believe that they will be more and more available.
And you actually answered my next question, if you're able to receive dialysis while on one of those medications. So that's good news.
Fortunately, there are no significant downsides for people who are receiving dialysis, whether it's peritoneal dialysis or hemodialysis. And I personally have 2 patients who are currently on peritoneal dialysis and receiving Wegovy, and it's been very helpful.
You mentioned a fellowship. Will you tell us a little bit about that?
There is an American Board of Obesity Medicine that was established, I believe, in 2011 or 2012, and people can pursue quote-unquote certification to be specialists in treating obesity. I don't believe anybody needs to have certification to be able to treat obesity, but it does help to understand the pathophysiology, the genetics, the epigenetics, and the mechanisms of action of all these drugs. So that has been my primary interest.
We talked a good bit about medication. What other sorts of treatments or interventions are available for patients?
Before the medications were available, the most successful treatment for patients with obesity was actually surgical. And there are different surgical procedures, such as lap bending or Roux-en-Y anastomosis or gastric bypass, if you will. But those are associated with significant morbidity as well, and they were not as readily available as treatments, primarily because someone's other health conditions or insurance coverage. I think counseling is very successful, counseling by primary care physician or counseling by a psychotherapist, and then lifestyle modifications. But the problem with the lifestyle modifications is that most of the lifestyle modifications are not followed through after a period of time. It's very easy for somebody to stop following certain, recommendations.
It's hard to maintain weight loss, especially if you're restricting and then you go back to the way you were eating previously, or maybe reincorporate something that you had restricted. It's hard to maintain that forever.
And you're bringing a very good point. One of the downsides of these newer medications like semaglutide and tirzepatide has been that once people lose the weight and they're very happy and they feel very healthy and they stop the medications, the vast majority of the patients will end up regaining most of the weight that they have lost. Then the question comes, do we have to be patients on these medications long term? And the argument has been made that, yes, we should treat obesity as chronic relapsing illness, and most people should stay on these medications maybe for life. So the jury is out. We'll have to wait and see how this plays out. But one thing is for sure, that the rates of obesity in this country and in the world are fastly increasing, and it's a very scary predicament that by 2030, 50% of us will qualify as obese.
That is a really sobering fact. So if you could leave our listeners with one piece of advice or counsel on how to maintain a healthy weight, what would you say?
It's a fight worth fighting. It starts with trying to be conscious about food and food choices. Try to avoid processed foods and highly processed foods, and try to increase physical activity by all means possible.
I feel like throughout time we've developed all these treatments and these interventions, but it all kind of comes back to that same basic of like, eat your fruits and vegetables, move your body. It obviously isn't that's the solve, that's the end, but those are sort of the basic building blocks at the root of all of it.
It is true. It's a lifelong journey. Again, the problem is that we live in a very quote-unquote adipogenic environment. We are destined to gain weight. And you can start with small steps at a time. Try to avoid the central aisles in the supermarket. Try to shop around the perimeter, which is usually the healthy part in the supermarket, and try to increase your activity as much as you can. Even 8,000 steps a day has shown to decrease cardiovascular disease and cardiovascular risk factors by more or less 30%. And 8,000 steps a day seems to be the magic number that we have to strive for.
Well, Dr. Menev, thank you so much for coming on The Journey Continues and sharing your expertise with us. And I know our listeners appreciate it as well. Maintaining a healthy weight can impact so many aspects of your overall health. Speak to your doctor or a registered dietitian to get some help. Get more information about diet and nutrition by visiting our website at nkfi.org. Thank you to Nephrology Associates of Northern Illinois and Indiana for sponsoring this episode. You can visit their website at nephdocs.com. That's NEPHDOCS.com. Prevention is a key part of our mission at NKFI. That's why at the end of each episode, we offer a health or nutrition tip.
Here's today's nutrition tip about weight management. People live in bodies of all shapes and sizes. While body mass index, a measurement of your weight to your height, and ideal body weight ranges may or may not be appropriate for you, they are used as a guide to know if you are at risk for developing a chronic health condition. Many people may think weight management is about being on an overly restrictive diet that includes intensive exercising. This actually sets people up for failure and is a large reason why diets don't lead to maintained success. What weight management is about is learning how to make healthy food choices at home and when dining out. It's about learning how to identify when you're hungry or if you're eating for emotional reasons. It's about finding physical activity that allows you to move through a range of motion, strengthens your muscles, and gets your heart pumping. And it's about making choices that will help you maintain your weight or allow you to gradually reduce your weight. It may seem easy to go it alone, but research shows that those who find support and professional guidance are most successful. Here are some tips from people who have had success with weight maintenance. Exercise is important and build up to 200 to 300 minutes per week. This is the equivalent of 30 to 40 minutes a day of activity. Stay hydrated, drink lots of water, and limit sugar-sweetened beverages. Eat whole, nutritious foods and focus on foods that are high in fiber. Eat responsibly and mindfully. Pay attention to when you're hungry and when you're full. Plan your meals ahead of time. This allows you to stay on track and make healthful choices. Find fun recipes online or in cookbooks to expand your meal variety. Decrease your screen time and do not eat while distracted. Monitor yourself by keeping a food log, measurements, or weighing in once a week. Join a weight management program for education and support. Build your own support group with family and friends. Keep a positive attitude and believe in yourself and your abilities. Think for the long term. The habits you are creating should be long-sustaining and not a quick fix. And make those changes gradual so that you can stick with them over time. With today's nutrition tip, I'm Melissa Prest, a registered dietitian nutritionist